MP joints.
MP joint.
The MP joints have 3 degrees of freedom, right? Flexion, extension, AB and adduction. And what's the 3rd degree of freedom? Rotation. But the rotation, so flexion, extension, and AB adduction, okay, those are physiological movements. You cannot actively rotate your hand, your MP joints. However, when you make a fist, okay, your fingers adduct and come to the center. That's a rotation, okay? If you need to grasp something that's cylindrical, that requires the freedom to rotate, okay? So it's actually what they call a joint play movement. Okay? So it's not, it's really 2 degrees of freedom. I said it incorrectly. 2 degrees of freedom, flexion, extension, AB, adduction, and the rotation is a joint play movement, which needs an external force to occur for it to happen, which means that when I put my hand around the cylindrical object, the freedom to rotate has to be there in order for me to grasp. The external force is another object, okay? So if I was lacking rotation at my MP joints, I would not be able to grasp cylindrical objects. I could do a hook grasp, I could do key pinch, but I couldn't do a cylindrical grasp. Okay? Now think about all the coffee cups that you would not be able to hold in your hand, okay? If you couldn't do a cylindrical grasp. So if I didn't have a flat hand, I could maybe hold like this. If I didn't have a hand that could grasp, but otherwise I wouldn't be able to do this, okay? So getting back rotation is really important, okay? So we're gonna go through first we're gonna go through the flexion extension for the MP, the PIP, and the DIP joints. And then we're gonna go back to the MP joints, do everything else, okay? So, the thumb is like everything else here. We have MP flexion of the thumb. So, what I need to do is stabilize the first metacarpal and do a mini distraction, and I can do anterior glide to increase flexion, and I can take her into more range and do anterior glide, take her into her end range, do anterior glide. Now, when I'm doing this anterior glide, initially I can just use my thumb, but now what I'm doing is I'm holding the first phalanx between my thumb and index finger and just, but hold close to the joint line, okay? So I can get a little distraction and glide. Then I'm gonna keep the MP joint in neutral, take her DIP to its end range, little bit of distraction, and glide. Okay, then I can go to the second metacarpal, hold at the joint line. Now, remember we did this one of the days in class, find the joint line for, remember we did hold up your hand, see where the, put your finger where you think the MP joint is, and many of you put your fingers here. The MP joint is pretty proximal, okay? So what I'm saying is, don't be stabilizing here. Don't be stabilizing above the flexor crease because the bone doesn't bend there, okay? Bend the joint, find it, little distraction, and you can glide into flexion or distraction, glide into extension, and you do that with all of the MP joints, okay? Then you can go to the PIP joints, a little distraction, glide into extension, and range, little distraction, glide into flexion. And then you go to the tips of the fingers. They're limited there, Rika. Okay, so we go to end range, little distraction, glide into flexion or extension, okay? So you go through all of the finger joints, and then if you want to increase, if you want to go back to, you will go back to the MP joints, and you're going to do, hold the metacarpal and do a little distraction, and then a lateral glide or a medial glide. That's to increase AB or adduction. And remember, your reference point is the middle finger, is the middle of the hand. So anything that's moving away from the middle finger is abduction, even if it's the fourth and fifth fingers, okay? Anything that's moving towards the middle finger is adduction, okay? And the middle finger can move away from itself, okay? So the middle finger only abducts. So I can do abduction, adduction. Stabilize the third metacarpal, little distraction. I can only move away from itself, so it's abduction, radial AB or ulnar AB. Then hold on to the fourth one, AB, AB, and the fifth one, AB and AB, okay? So those, and then you have rotation. Rotation at the MP joints, we're going to start with the second. There are basically two ways to do it. You can take a long hold right along the first phalanx, okay, and just rotate it like that. You don't want to cross the joint line. You don't want to hold it from the DIP and do this, because you're going to create hypermobility at the PIP and DIP joints, okay? Here and here, okay? And here and here, and come here and here, and here and here, okay? So that's one way. The other way is some people will bend the PIP joint and just hold it and do like that. Okay, that way
Easy.
they're not holding from here. Okay. So, the hand is very labor intensive. You got lots of joints, and every single one of them may need to be worked with. Okay, because you want the person to be able to flex their DIPs to 90, you want them to be able to flex their PIPs to 120, and the MP joints to 90 to 100, depending on their own skeleton. Okay. Now, other thing that I want to show you is not only do we do mobilization to get opposition. Opposition is very, very, very important in the hand. So the opposition can be, or lack of opposition can be, because the CMC joint is tight, and it can be the web space is tight. So what you want to do is soft tissue work, just like you did at the middle radioarticular, middle radio-ulnar articulation, soft tissue work. You can do soft tissue work on the dorsum of the hand, in the web space, on the volar part of the hand, and stretch the web space. Okay. The other thing that you want to be able to do is have the patient learn that they need to how to rotate. Okay, so they need to come up and around, up and around, up and around. The other part of opposition is, do you remember that the little finger has an opponent's digiti minimi? Okay, wow. So you want to mobilize that little finger into coming down and around. Okay, so then you can have you can help it and then bring your thumb to your little finger and hold it there, and then let it go and bring it together. And so you can create this little cupping movement, okay, and let it go. So there's lots of things that you can do with the hand, but when you get somebody whose hand needs work, it is very, very labor intensive. It's not something you can just say, here's some honey, squeeze it. You need to set it up so that the squeezing is effective. Okay? So if you have patients with hand problems, send them to OT. No, do not. Treat them, but one of the things that I learned is that certain patients you can definitely treat, and certain patients should go to a certified hand therapist. Okay, know what your skills are. If your patient has had complex surgeries, re-implantations, tendon transfers, tendon repairs, and they need multiple types of splinting, send them out to a specialist. If it's a post-immobilization stiffness and soreness, we can handle that. But you need to be very, very diligent in how you handle it, because if you don't work with the hand enough, then they have a disability. It's a huge responsibility.
So 2 points. One is that certified hand therapist, it could be OT or it could be PT. So it doesn't have to be necessarily OT, but rather than a certified hand therapist is a PT as well. The other thing that I wanted to demonstrate to you guys, although it is not particularly for exam, but rather than understanding what